Okay, chapter 42, some of the stuff which we have done that we did in the group work in class. So I'm going to cover some of this stuff, and then make sure you watch to the end because I'm going to give you a specific reading assignment that you must do before the start of class next week. So there's going to be questions that I'm going to go around and ask about this, so you must watch and listen to what the reading assignment will be at the end. So we'll go through some of this stuff. We've already done this. So we already did all the headache stuff that we needed to do. Make sure you review the PowerPoints. You have that page 854 with the etiology. We talked about the auras versus the non-auras. We discussed that together in class. Make sure you read chart 42.2 to understand the three types. And so we can move right past that. So then we briefly, well, no, we didn't briefly. We actually discussed quite a bit with the epilepsy and versus the seizures and the different things about it. We did all of our group work together, which actually I felt was awesome, and you guys did a really nice job with that. Here's, again, just a list of some things that can cause seizures that you need to be familiar with seizure precautions. So it's important. Your book talked about how whether or not having padded side rails, it said that the patient may be embarrassed. The safety is going to be first. So if there's seizure precautions, you're going to follow whatever the policy is for that. But also, if we know we have a patient for a high risk of seizure, we want to make sure that our room is set up. So that's making sure that we have oxygen ready to go, that our suction equipment is there and ready to go and all set up. That, you know, if I'm going to need some kind of an oral airway, that I have that available. And hopefully, if the patient's in the hospital, they already have IV access. But again, following the policy as to whatever the seizure precautions are when it comes to like padded side rails and such. So with the seizure management, you guys once again did a really great job. I think that everything that is in here is also reinforced with the stuff that you did in class about the patient's safety and laying on the side, not restraining or sitting on the patient, not putting anything in the patient's mouth, our observation and documentation. The documentation that the last group did for us was great. They talked it out and put it right up there on the board, and was all four groups did a very nice job. But you want to make sure that observation and the documentation is thorough after the fact. So we did discuss medications a little bit. We talked about the benzodiazepines like Ativan or Valium that's given, and we also talked about Dilantin that we can give to the patient. So you know, it's knowing that these medications, like the benzodiazepines, immediately for the seizure, Dilantin is something we can give, or longer-term management, and then the other anti-seizure medicator or anticonvulsants that we've discussed in pharmacology, all of those medications that we've gone over. And for those of you from MedSurg 2 who are watching this for fun, you guys, we discussed a ton of this in mental health, all of the anticonvulsants that we use for like bipolar disorder, many of which can also be used for seizure management for that. So you can do a review of those medications, but that would include things like the Tegretol and Lamictal and Keppra, the different ones that we discussed for that. So with drug therapy, so the one thing I really want you guys to see here is that this medication is never, Dilantin is never administered with warfarin, also known as Coumadin, which is a blood thinner, because it decreases the effects of warfarin in the body. So it's really important that you know that and be aware of that. So family education, you guys also did a good job with this the other day in class, where we talked about the things that the patient and the family need to be taught, specifically about driving and transportation. And remember, it was 6 months to a year in which the patient had to be seizure-free before they could get a limited license. But different other safety things, compliance with their medications. And then remember, it's important for us to know what kind of social services we could help with medication costs. And again, the support groups, which is the ever so important thing that we know about support groups, so we can help our families and our patients to get the help that they need and the support that they need. Be sure to read these 4 different interventions that can be done with surgical management. These could be part of some questions that are asked in class. So then we're going to move into meningitis. So there's viral and bacterial meningitis, okay? And then there's this video right here. Let's see what I think about this here. So it's kind of dramatic, if I'm honest with you guys. So make sure you watch it, though, because it does a nice little overview about things with meningitis. And meningitis is serious. So make sure you go through and just watch. It's 2 minutes and 41 seconds, so it's not a very long watch. And then so your symptoms of both viral and bacterial are similar. We're going to see things like a change in the level of consciousness, photophobia, remember what that is, that sensitivity to light, a headache, nuchal rigidity, this is neck stiffness, phonophobia, that's sensitivity to sound, muscle aches, nausea and vomiting. Pages 863 through 864 have more symptoms. I'm thinking that was not supposed to show up that way. I think it was probably supposed to have a actual link to click in. So let me just, I don't know here. Okay, let's go and take a quick look at this. Let's see what this is. Oh, it's the same one. So you guys don't need to look at that one. It's the same exact one. I'm not sure why it put it over there like that, but it did. So anyway. So your physical assessment. So this is going through the same things actually that I just listed. It's in here again. And then the Kernig's and Brudzinski signs. If you click on that, that's also a quick little video of some students demonstrating what both of those look like. You're going to want to know what those look like, so make sure that you go in there and watch that. And then laboratory assessment of meningitis. So, you know, doing the cerebrospinal fluid analysis is pretty much the definitive tool for meningitis. So be sure you read through this right here. You got a reference that you can follow to read more there at the bottom. Your book didn't go into this a ton, so I wanted to give more information on it. But the big things that they're looking for when they do a CSF is it clear or is it cloudy? Because cloudy can indicate that there's WBCs in there, right? So, and then the other thing they're looking for is there protein in there? Because typically there might be a little bit of protein, but not a lot of protein. But they will see an increase in protein with meningitis. And then the glucose count, because glucose levels decrease when there's white blood cells and other things in there that in comparison to where it normally should be. So that's where the definitive is going to be. And I'll share more with you guys about that when we meet together again. So the drug therapy, so there's your stuff. Normally what's going to happen is the broad spectrum antibiotics are going to be started. The problem with determining whether it's viral versus bacterial is they have to wait to see if the cultures grow, okay? So, and that takes a little bit of time. Cultures don't happen overnight. So what happens if somebody comes in and they have the spinal fluid drawn and it shows that this is some type of meningitis, then they're going to treat them as if it's bacterial until they've ruled out the bacterial. What's the problem with that, especially like in children, is that, you know, those big broad spectrum antibiotics cause all kinds of, you know, like side effects, and they're really caustic on the body, and for kids are painful, can cause bone issues and all kinds of stuff. So, but it's the risk versus benefit, like always. So we're going to be giving lots of fluids. Your book did say in there that steroids are controversial in use. It does not go into detail into that, and I actually am going to look into that more because I'm interested in what the controversy with it is. So, and then prophylaxis for those that have been in close contact, especially if the patient has bacterial meningitis. So when you think of viral versus bacterial, people always say, I know one's worse than the other, and that is true. Bacterial is much more worse than viral. Viral's still bad. I mean, a patient is very, very sick. 2 years ago, was it 2 years ago or 1 year? 2 years ago, I had a daughter hospitalized early for 5 days for viral meningitis. So it's serious, but it's likely not to kill you the way that bacterial is. I want to say it's like a 50% chance that, and I'm not quoting that for a fact, but I think it's close. That's close to where the statistic is, with 50%. You know, of it being, it can be fatal for the person. So, okay, so this is the part where I wanted to tell you guys. I want you to read, and this is for MedSurg 2 as well. I want you to read pages 867 through 882. Specifically, I want you to be sure for Parkinson's disease and for dementia, primarily for the Alzheimer's disease. And then, sorry, I'm looking through here as I go, because I was just going through all this. And then Huntington's disease. I want you to read those 3 different diseases and know these, because they're going to be important for you to recognize and know everything behind them. This also is going to show me who is reading and who is not. I really need you guys to be doing this. So 867 through 882, for both classes, when we get together, we will be going around the room and different questions being asked about these things. So you're definitely concerned with the pathophysiology. You're concerned with what the nurse is going to see, what type of interventions, and then specifically as you're going through, anything that you see in blue. I'm really big on blue words throughout your book, and us knowing what those blue words mean. Many times that's what's going to be on your test, is fill in the blanks. So they're a like lighter blue, not your dark blues like health promotion and maintenance, but things like cognition, apraxia, aphasia, agnosia, sundowning, all of those words that you see in the blue. I want you guys to know. Again, those end up showing up on my test because they're vocabulary words in which you need to know. So follow this on here, these slides. So you see you have your patho, your cause, your preventative, all of this stuff, and read your book as you go through. Much of your test will come from these areas in which I assign to you. So if you did not read, you will not likely pass those questions, okay? I want you guys to do that because it's, you know, this is a give on my end, as well as you need to demonstrate back to me that you are doing this. Bring your questions to class this next week, specifically on those 3 things and things that maybe you didn't understand, or better yet, post them in the discussion board under questions so we can discuss them there. So anyway, that's what I am assigning for you to do with this. Please do it. Let me know if you have any questions.